For everyone on the line, I'd like to welcome you and say thank you for joining us today. I am Trish Hutcherson, Orion Health Corp's Marketing Director, and I will be with you through today's session as your moderator. On behalf of everyone at Orion, we hope you enjoy today's presentation. Before we get started, I would like to run through a few housekeeping items. Today's phone lines will be muted for the duration of the session. If at any time you have a question, please feel free to enter them into the GoToMeeting dashboard on your screen. Technical and logistical questions will be answered in real time. However, any questions related to the content will be answered at the conclusion of the presentation. After today's session, you will receive a short survey, and we'd ask that you complete it to let us know how we did. And with that, I'd like to introduce today's speaker, Christy James. Christy has been affiliated with radiology and medical practice management for over 27 years. She is currently responsible for the imaging revenue cycle for Massachusetts General Physicians Organization, which is affiliated with the Massachusetts General Hospital in Boston. She has held positions with Dartmouth Hitchcock Medical Center as the radiology business manager, as an independent consultant for the Department of Radiology at Maine Medical Center and Southern Maine Medical Center, and as the practice administrator for the Medical Practice Division at Southwestern Vermont Healthcare. She's been a member of the Radiology Business Management Association since 1992 and is currently the president of the New England chapter of RBMA. She is the past chair of RBMA Payer Relations Committee and has served on many RBMA committees such as the Data Collections, Programs, and Nominating Committees. She served on the RBMA Board of Directors from 2007 through 2009 and received her RBMA Fellowship recognition in May of 2012. Christy currently serves on the ACR Managed Care and Utilization Committees and holds a Master of Science in Organizational Development from Antioch, New England Graduate School. And for everybody on the line, I would like to just tell you that you will be receiving a copy of today's slides at the end of the session via email to the email address that you registered for the program today with. And Christy, with that, I'd like to invite you to go ahead and get started.
Hi, everyone, and thank you, Trish, for the introduction. I am sure the audience listening to this webinar today is very sophisticated in terms of revenue cycle management. But I hope with the information I'm going to provide you with today that I can give you additional tools to manage your revenue cycle. The revenue cycle is very complicated, as you all know, and one that every business manager needs to understand as well as their radiologist. Today's learning objectives are a guide to what I will be talking about today. I'll be taking questions at the end of the webinar, and Trish will be our moderator, and we'll be facilitating those questions at the end of this presentation. Some of the learning objectives I'm going to cover are defining certain components of the optimal revenue cycle. And then I will go over some tools that I will share with you to ensure that you're capturing your charges and your claims are getting paid. And also just understand the denial management process and the challenges your in-house billing operation or billing service has collecting your money. And we're also going to be able to identify possible areas where money may be left on the table and how to avoid them. And also better understanding of the payer payment policies and pre-certification programs. So radiologists are currently under a lot of pressure to control ever-escalating costs, which have resulted in reimbursement cuts for imaging. I think you're very much aware of the many payers that in the government that have perceived imaging as overutilized, and it's important that providers of imaging be more engaged in the reimbursement and utilization of imaging more than ever before. Now is the time to act in understanding how healthcare reform is going to affect your practice or hospital. I'm certain there are many people listening on this webinar who are already beginning to feel the effects of the many cuts imaging has endured over the last several years. It is imperative that radiologists get involved with their hospitals during key negotiating opportunities while designing new payment models. For example, accountable care organizations, bundled and or global payments are some of the different models that are out there now. Be part of care redesign opportunities, which are very important to reduce costs and imaging utilization to avoid being left behind as healthcare reform moves forward. And then I read this article recently in the ACR Bulletin called Adapting to Change, and Chris Hobson says it very well. It says, if radiologists do not change the way they do business, they will not thrive as a profession. If they do not, they risk being left behind as healthcare reform moves forward. Bibb Allen, I'm sure a lot of people on this call know who he is. He's in the ACR, American College of Radiology, and this is something that he also quoted in the same article. If radiologists can't figure out a way to save the healthcare system money while providing good care, the only thing we'll be competing on is price, and I think you probably are starting to realize that now in your areas. The market overview. CMS and Congress have cut imaging payments 12 times since 2006, and more cuts are on the horizon, and I will go over that later on in this slide deck. The commercial payers have adopted the same cuts, stating it is industry standard. And I'm not sure if you've all recognized this, but for us here in Massachusetts, for example, there's one of the reductions that I'll be talking about. One of our payers has adopted that as industry standard, which it was a CMS policy change, and that one of our commercial payers recognized that CMS is setting the industry standard for the country. So obviously that's something that we all have to avoid. Radiologists are feeling the effects, and they're pressured again to control costs and improve quality and so forth. Some of these cuts, as you can see here, started back in 2006, started with the MPPR on the TC component, and it moved on through the years. And most recently, you see in 2013, we all endured the 25% professional component. I'm sorry, back in 2012 it started, but in 2013 the 25% cut to the professional component was also extended to multiple physicians within the same practice for the second imaging or third imaging procedure. For example, if you have one specialist that reads the CT of the head, a second specialist within your group reads the abdomen or the pelvis or the thorax, that CMS considers that in the same family of codes, and that your physicians, no matter if they're different NPI numbers, you're still going to get the 25% reduction on the second or third or more exams in that same session. Again, that's one of the things that are out there right now is the definition of same session. That is something that is ACR and RVMA has been actively trying to get CMS to clarify what they mean, what same session is. And we don't want to push it too much, because they may come back and say same session means same day. So we'll leave it as same session right now, and that if there's multiple physicians within your group, your highest RVU is going to be paid at 100%, and your second or third lower RVU value procedure is going to be reduced 25%. The next one on the horizon is going to be in 2014, and that starts on January 1st. It's embedded the American Taxpayer Relief Act, and that was scored at, CBO scored that at $800 million over 10 years. What that is CMS is going to raise the utilization rate to 90% from 75%. They started this back a couple years ago, where they took your utilization rate was at 50%. They recognized that you use your equipment more than 50% of the time, and this is equipment over $1 million, that you use it more than 50% of the time. So we, as RVMA, said, well, wait a minute, we feel that we only can utilize, you're utilizing this advanced imaging equipment 62% of the time. Yeah, and however, we fought this battle over and over the years, and we lost, and now the CMS is going to raise the UR to 90% on the technical component in your MPFS fee schedule, and that is going, you need to go back into, to understand your RV values and determine how much it's going to cut your reimbursement going forward. What to do? Radiologists need to be visible and at the table for all healthcare reform discussions and healthcare redesign opportunities. More importantly, you need to know your revenue cycle. It's the biggest asset of your practice, and it must be understood and monitored so you can sustain your cash flow and so you can steer your practice through the unpredictability of healthcare reform. So let me go into the certain aspects of the revenue cycle. I'm going to go into the details of what I think an optimal revenue cycle looks like and some of the tricks of the trade that I've learned over the years. And the first is the beginning of the revenue cycle. And that starts with scheduling and registration, and then goes into the pre-cert and prior authorization. I'm going to get into that a little bit later in our discussion. And then the charge capture and radiology note documentation and finalization. And then, of course, it goes on to coding, and I'll get into computerized assisted coding and what that means and how it can improve your revenue cycle. And then charge posting, claim submission for payment, and so forth. And then the claims are paid approximately 14 to 60 days or later, depending on your payer, after claims submission. Some payments can be made daily or weekly, depending on your payer. Denial management is a very complicated, and some consider it the black box where you can decide as a practice how much you want to invest in getting your denials paid. What is your agreement with your billing company on how much they should roll up their sleeves and get in there and try to get all your claims paid? Or do you want to not even bother with the rejected chest x-rays that you know you don't get a large return on your investment if you're having to appeal those once or twice, especially if you're only getting paid $6, $10 for a chest x-ray. The cost of appealing those chest x-rays would be too much money. And then we go into identifying front-end operations to minimize those rejections. And then, of course, you've got compliance, internal audits, RAC audits, and I'll get into that a little bit later. So the devil's in the details, and the registration needs to be obtained, and it has to be right the first time. And this is the only chance you get it right, and this is to have robust registration processes up front. And getting it right can decrease denials, and it can avoid the rejections, and it also will decrease the cost of managing those denials and also chasing after the claims, and improve cash flow, obviously. And then this is an opportunity to implement waivers, or ABNs, which are advisory benefit notifications. And those on the call don't know what that is. It's a Medicare waiver that you have to use for your patients that are Medicare, that have Medicare, and that are going to have a procedure that probably is not covered by Medicare. So your patient has to sign that up front, understand the cost, and what to expect to pay. Other waivers you can implement, depending on your payer, is just a one form. We use just a form that we present to the patient upon check-in, and the patient recognizes how much they will be charged for that service. You can decide whether you want to collect at that time, or if you want to collect copays for your procedures. As we all know, the technical component for these procedures, the copays can be very high. I've seen them as high as $350 for copays, depending on the benefit plan of the patient. Those are all areas where you can probably maximize your reimbursement if you were able to have robust registration processes up front, and collect the copays and financial clearances is robust enough to do so. The next part of your revenue cycle is obviously after registration and scheduling is to get the pre-certification for your advanced imaging services and or prior authorizations for your procedures, depending on what payer your patient has. A robust pre-cert process is essential for the technical and professional component. And also, I will get into in another slide what we've implemented here at Mass General and also other areas of the United States is a centralized physician order entry system and a clinical decision support process, which helps facilitate the pre-cert process of your whole registration program. Also, I found this one bullet item out of one of the articles I was reading recently, and it just stood out to me, that MGMA said that most practices leave between 5% and 30% of their reimbursement on the table because they lack proper processes, staffing, training, or technology. So you can see how important it is to possibly put a lot of effort into making sure your registration, scheduling, and pre-cert processes are robust enough on the front end. Then going forward, you have coding, and coding needs to be very accurate and needs to be coded from the finalized radiology report. As you all know, documentation is extremely important. It could vary, depending on the documentation, your reimbursement can vary. Your coding could be undercoded depending on insufficient documentation or resulting from insufficient documentation, or you can maximize your coding if your documentation is distinct. And also, oops, I'm sorry about that. I don't know why that happened. This one? Sorry about that. Here at Mass General, we use computerized assisted coding, which we auto-code 30% of our session numbers, or excuse me, of our radiology notes. And when I say auto-code, they go direct to bill without any manual intervention, which is very important when you have so many radiology reports you have to code. And some other clients that I have had the privilege to work with, or other colleagues of mine, have used CAC and have up to 60% of all their radiology notes, including IR, auto-coded by these CAC programs. I'm having difficulty here. Oh, what happened here? Not able to advance the slide. Oh, here we go. Excuse me. Sorry. So how did we get here with the pre-certification? The rapid growth of high technology diagnostic imaging scans year over year were increasing 20%. So obviously something needed to be done when you had double-digit growth year over year for advanced imaging. Medicare expenditures for HTDI procedures rose from $3.6 billion to $7.6 billion from 2000 to 2006. That was a 17% annual increase. Obviously, we needed to do something because utilization was out of control. So in response to the utilization rates, healthcare plans launched prior notification programs, or what I could say RBMs, radiology benefit management companies, to ensure appropriate use of HDTI. It spawned a new service within our industry, a third party, let's say, who manages our imaging. So the physician's concern with RBMs, it took the decision-making processes away from point of service, and it added administrative costs and lowered clinic efficiencies and so forth. And I have seen healthcare systems add several FTEs to monitor the acquisition of pre-certs. In my experience, we developed special web-based pre-cert databases for the pre-cert teams to manage. I don't know of any healthcare system that hasn't incurred some kind of operational cost to manage the pre-cert process. When the professional component isn't responsible for getting a separate pre-cert from the technical component, if you're billing for the professional component, you can get denied and receive no payment, even if you were not the responsible party for who failed to get the pre-cert. So you need to work with your hospitals and imaging centers to ensure that their pre-cert process is robust and provide assistance where needed. The pre-certification process, it has succeeded. I mean, they have reduced the double-digit ADI volume, and in some cases have reversed the growth to negative, like 1%, 2%. Our pre-cert is obtained from either the payer or the radiology benefit management company, but there are payers that have their own authorization program, i.e. the United Healthcare program. And then the professional component doesn't typically require pre-cert, like I had just said. So how big is this RBM, our RBMs in our industry? They cover over 153 million lives, and that was as of 2010. And that was nearly 70% of all covered lives in the U.S. are affected by the pre-cert process. And let me go back to that. I just want to point out that the 5 RBMs in our industry are NIA, and I'm sure a lot of you have heard this, NIA, CareCore, AIM, or American Imaging Management, Med Solutions, and Health Health. So clinical decision support is a part of a centralized physician order entry system, and it's designed to provide appropriateness criteria at the time of scheduling the advanced imaging scan based on ACR appropriate criteria and evidence-based medicine. CDS can also provide the patient's imaging history and radiation alerts at the time of scheduling. Many articles have been written regarding the effects of CDS has on decreasing utilization and inappropriate imaging. Medicare is considering a CDS product called ACR Select in place of an RBM at this time, which is good news for us. Commercial payers have adopted CDS in place of RBMs in Massachusetts, in Minnesota, and other parts of the country. It is definitely gaining popularity using CDS. Here in Massachusetts, Mass General has presented CDS to United Healthcare in hopes that our MGH physicians don't have to use UHC's prior auth program because we already they are already being educated on our own internal CDS product. We're waiting for their response. ACR also has developed a program called Imaging 3.0, which encourages radiologists to implement tools. Utilization management is and will be a centerpiece of controlling costs, so they came up with Imaging 3.0, and it's about decision support instruments such as the ACR appropriateness criteria and also their ACR Select, which is that CDS kind of a scoring model per se on the appropriateness of ordering high-tech imaging. Radiologists must find ways to increase their relevance by improving patient care beyond just image interpretation. And so for more information about Imaging 3.0, I've added the website here. So the revenue cycle continues. You've gone through the registration component. You've gone through the pre-certification. You've gone through the coding. Now we've gone to a place where, for example, the hospital sends your interface or your billing batches to your billing service, like Orion, for example. And Orion, I'm not sure, has claim scrubbers, but in my billing system we have claim scrubbers that reviews the claim encounter for local medical reimbursement policies and compliance reasons. What we're doing with these scrubbers is to ensure the encounter is as clean as possible prior to processing it. And then the second piece is, what is the billing lag time? And this is something that's very important for your practice to understand. What is your billing lag time from time of service to payment submission? So depending on your practice, faster isn't always better, but for example, in my practice, I feel that I need to get the lag time from the time that the time of service to the time that I submit the claim, we need as short as possible. But at other practices are saying that maybe I need to extend the lag time so I can receive accurate registration data from the hospital. So that's something you need to decide for yourself. And then again, I said payers can pay from 14 to 60 days or longer depending on your contract. And does the payer pay daily or once a week? And your practice cash flow depends on that. Now I'm going to get into denial management. And I want you to ask yourselves, are you leaving dollars on the table with your billing service or your in-house billing operation? Coding rejections, for example, can be minimized using computerized assisted coding. Incorrect registration can impact your pre-certification process as well. And the RBM and/or insurance company may have the coding as members at the time of service. For example, what I mean by this is you can submit a patient's insurance through a clearinghouse to see if they're still valid for that insurance. And for some reason that insurance has not updated the clearinghouse or somehow it misses and your patient gets a pre-cert, for example, for Blue Cross Blue Shield. You've done all your work, you've got the pre-cert, you've done the scan, and you haven't, and you think the patient still has Blue Cross Blue Shield. When you finally submit the claim, the patient no longer has Blue Cross Blue Shield, and the pre-cert gets, or the claim gets denied as patient not a member at that time of service. So then you turn around and rebill the patient's insurance that they have now. Let's say they have Tufts or Harvard Pilgrim or something like that, or Aetna or Cigna, and that you have to go back and try to appeal that claim, saying that we thought the patient had Blue Cross Blue Shield at the time of service, but now that they have Aetna, excuse me, sorry. And I think when I accidentally hit my mouse, it jumps, and I apologize for that. So anyway, I just want you to be aware that your insurance and registration verification is extremely important at the time of scheduling, so you can get the pre-cert correct at the right time. The other pre-certification issues that we've come across is, for example, you still get the pre-cert and it's not medically necessary per their LMRP, the payer's LMRP. And that's unfortunate because you've done the administrative burden to obtain the pre-cert, and all of a sudden you come back, you get a denial because it's not medically necessary. Or, like I said, the wrong insurance. And another issue you could have, if the pre-cert validation period has expired. That happens quite often. For example, you have a validation period of tomorrow for the next 30 days, and what happens, the patient can get in today and have their MRI, and you haven't gone back to revalidate that validation period. Or the CPT did not match the pre-certified CPT, and this is for finding a lot in depending on the RBMs, and they're realizing that they can get very specific on some of their CPTs. So, for example, you have a CPT certified or pre-certed for a CT head with contrast, and you end up billing it with a CT head without contrast, it could still get denied. The other area that you can be leaving money on the table, obviously, is non-covered services. And the CPT or ICD-9 code did not match the medical necessity or is considered non-covered. I'm sure we all know what those particular procedures are, and you probably know that in advance. And also you have to let your in-house billing operation or your billing service know about these non-covered services in advance and saying, hey, I'm going to be doing this. Here's one that's a very good example, like tomosentences. Maybe you want to bill that out, you know it's non-covered, and in most cases non-covered, so you might want to do an auto write-off on that when the claim comes back rejected and that the patient doesn't receive a bill. Those kinds of situations happen. The other thing is that I'd like you to recognize that there's some radiologists that may not get paid because the payer didn't recognize their specialty. For example, a lot of our contracts require, here locally in Massachusetts, require the radiologist to be require all our radiologists to be board certified, and we will not get paid unless the radiologist is board certified, and that's usually Blue Cross Blue Shield in Massachusetts is one of those. Also, the other thing that you need to be aware of is are all your providers within your group being paid the same rate for the same service. We recognize that we found out that some of our payers are being paid statewide fee schedule versus contracted rates, and we have to monitor that all the time. Underpayments, continually monitor third-party payments to ensure payers are reimbursing at your contracted rates. I'm sure a lot of you have billing services that do have that in place. Another area is, you know how all these payers are putting in these payment policies. You want to make sure that they can implement them correctly, like the MPPR for CMS. I think they got that down pretty good. They can do the MPPR pretty accurately. Now the toolbox. This is something that I use on a routine basis that help me monitor my revenue cycle and avoid that black hole. And they include a dashboard that I watch on a daily basis, and it gives me it details every aspect of the revenue cycle and the accounts receivable that I have on the books. And I'm sure your billing service or your in-house operation has a dashboard as well. I've seen some billing services that have some pretty sophisticated dashboards that you could see where your claims are at any given time, at any time during the day or month or week. Review your revenue cycle daily, weekly, monthly. Identify your trends and make year-over-year comparisons for each reporting period. Most billing services offer many different types of reporting necessary to have complete transparency, and that's what you really need with your in-house service or billing or your in-house operation or the billing services. You want complete transparency at all times. Understand the reports that they provide you that can guide you to understanding the whole revenue cycle, because it is complicated. And use these reports. I've had physicians call me and say, I don't understand what's going on. I've lost revenue. I've lost 10% of my income over the last year. I don't know why. I don't understand. But if you were able to talk to your billing service or your billing manager, you could probably get a better understanding of what's going on with your revenue if you were able to benchmark it compared to prior year, same time, and so forth. And then also look at your first-time rejection rates. And by doing that, I am also advocating that you develop a work group within your organization that represents every facet of your revenue cycle: your billing manager, your coding, your compliance, radiology. You want representation of the professional component, someone from the hospital finance or someone from the hospital radiology department. Have your radiology information system or RIS IT there represented at this meeting, and have your front desk staff and so forth. Meet biweekly or monthly to review rejections and other operational workflows that affect your practice by using first-time rejection rates and reporting and so forth. And you maybe can uncover some of those black holes in your revenue cycle. We have one here at Mass General, and it's called the Imaging Revenue Cycle Group, or IRC. We have fun with these meetings. We meet once a month, and we have a series of projects that we're working on to optimize our revenue cycle at all times. Another component of your revenue cycle, or the tool that you need to be aware of, is AR aging. Some practices don't pay attention to that. Other practices do. We do. In my 27 years of doing this, I always look at my AR aging because it's telling me how fast I'm getting paid. So you can come up with different ways to determine what the days are in AR. RBMA is a good place where you can get those definitions of formulas or formula definitions to determine how you want to define what AR aging. But the one that I use is to determine one day equals the previous 6 months of charges divided by the number of days within that 6 months. Let's say that 6-month period is 180 days or 181 days, and then you come up with an average daily charge. And then you take that average daily charge and you divide it into your total accounts receivable, and that will give you the number of days that you have in AR. And then you want to benchmark that. And I'll show you later on in my slide deck how you benchmark that. So the collection rates are another area where I think you really need to focus on. And it tells me, as a billing manager over this immense revenue cycle, as you can imagine, that I manage here at Mass General Hospital, is how fast are you collecting your payments. So we have a mechanism where we can, and I'm sure your billing service or your in-house operation can do this as well, is you want to figure out, for example, today, all your April dates of service, how many have been paid. So I'm looking at 87, 88, 89% have already been paid. That's not so bad. And then you look at your January dates of service, because that's 6 months ago, and you're looking at, say, you should collect 97, 98, maybe even 99%, depending on what type of practice you have. I have, obviously, it's a large hospital. We have a lot of problems in collecting some of our claims. So I feel 97% is not that bad for 6 months. And then write-off. It should be less than 2% of your gross charges, or less than that. And RBMA has benchmarks that you can adhere to in guiding your practice through all this. And I would advocate that you do join RBMA, or that you have someone in your billing service be part of RBMA so they can have access to some of these benchmarks. So you can benchmark your practice against other like practices within your, for example, if you're an imaging center, academic, or hospital-based. So other key indicators that I monitor are, for example, here I put together this one snapshot where I take all the accession numbers that in 1 month, for example, all the accession numbers that have been created in the last 4 months, let's say, out of the RIS system. And the RIS will, I have a special program that gives me all the accession numbers as of the last 4 months that have been created. So when I take those accession numbers and I'm able to bump them up against all of the accession numbers that I have received in our billing system or the professional billing system, to determine where they are in the whole billing cycle. So to start with, the C status that you see on the first line, first of all, the first line you see the total accession numbers, but the next line you'll see the C status. C status means it's never been read. And it's been completed by your technologist. The exam's been completed in the res by your technologist. However, it has not been sent to the radiologist to be read for one reason or another. So you monitor that over time. The next one, no accession match, is the session number was not found anywhere in the systems. And you can sometimes find out why it was deleted or there was something happening there. And then final ready to bill, it's depending on when you're running this, because I run this weekly, on a weekly basis, and sometimes biweekly. And then biweekly probably is optimal, because I think weekly is a little bit too much, but biweekly is optimal to determine if you're leaving any money on the table, if there's any accession numbers that are stuck somewhere. Let's say you had a billing file that got duplicated, and you need to understand where that is in your revenue cycle, and you can see how I've noted that on the right-hand side, that when I say match transaction aggregated in test, that means instead of using that word deleted, I said aggregated. And if you look to the right, I have 2,913. Well, we had duplicate files, and we were able to catch that in our billing system, and I'm sure a lot of your billing services out there can do the same, catch the duplicate files, and we were able just to immediately delete those before they even went out the door. We have a lot of fail-safe programs, so we will never be able to send out a duplicate claim. So going back up to the top, obviously, there's the P status, which is it's been read, but it hasn't been final signed. We do not bill any of our services unless the report is final signed. Obviously, the coding based on final signed report, and so the documentation follows that claim all the way through the system. The other part after the deletion, once it comes over to the billing system, is that the transaction edits in test. Remember that scrubber I was telling you about? We call it a transaction edit system, or test. So we build a lot of test edits that we capture, and we were able to, for example, we're missing a rendering provider, or the provider is not credentialed with that payer, and so forth. It ends up in these test edits or scrubbers, and we're able to fix them before they go out the door to the payer. And then you can also see where it says pending extraction. We're waiting for the claim to go out the door at that time. So you could monitor your session numbers, let's say as of May 15th. You can look to see where all your January dates of service are. Have they all gone out? In February, where they all are in March, and where they all are in April. And we monitor that every week and every 2 weeks. Also, I have another indicator that I use. It's just simple, very simple, and I know that all your billing services and operations, or billing operations, have your own, but this is just something that I put together. It's just a real at-a-glance, simple dashboard. And what I want to do is just, okay, what's my days in AR in March, for example, I have up here. And I benchmark it against UHC, which is United Healthcare Consortium, and their 75th percentile. And then I also look at RBMA 75th percentile to see how I gauge my practice, or my billing operations. And I'm at 31.5 days. I can tell you that I've been as low as 27 days. It all depends on how the month ends, how many paydays, how many payments I receive from Blue Cross Blue Shield. All kinds of things happen in the month that can skew those numbers. And then again, your match net collection rate at 2 months and 6 months is also listed here, comparing those to RBMA, and then also your billing lags and so forth, and the write-offs. And also, I monitor how many days of your AR is over 120 days old, and I take out self-pay, because self-pay is growing, and it's growing rapidly because of the higher copays and deductibles, and we do not have a robust system up front to collect those deductibles and copays. And it's unfortunate that us as providers are having to take on that administrative burden to collect the copays and the deductibles. I do know that there are some payers out there, I think it was in Missouri, I believe, that have recognized the administrative burden and the cost that the providers are incurring to collect those copays and deductibles, and they're realizing that they will go after the patient for those deductibles now because they're the ones that are implementing this benefit plans and increasing the deductibles, but they're also transferring the burden of collecting those onto the provider. So write-offs can tell you the whole story, and the whole story is in your write-offs is it will tell you what's being written. Whoops, excuse me. All efforts are exhausted and the claim is written off for several reasons. And so most of the time it's your medical necessity write-off, your non-covered, and final limit. Now final limit can be prevented, and it all depends on how quickly your radiologists are reading, and also making sure you're clearing out all those C status, you're clearing out the P status, you're on top of all that, and making sure that the final limit is prevented. Because some of these payers have very stringent filing limit time periods. I have one payer that is restricting us to 60 days from time of service that we have to get the claim out the door. So obviously, pre-certification is one of those top ones that we endure on that we write off a lot. I don't know, from a percentage of gross charges, it's not that bad, but it's something that we're always striving to do better on. Write-off should not be more than 2% of your gross charges, like I told you before, and you want to strive to reduce this from knowing the warning signs that I described earlier in the slide. So there's no non-clinical activity more important to your practice future than taking action to get paid for services you provide. So what's in the future? And that's the scary part, I'm afraid. Just recently, we just found out that, I told you about the UR, the 75% to 90%, but most importantly, what's out there now is the outpatient prospective payment system. There's the proposal by CMS to reduce the CT technical component by 26% and the MRI reimbursement by 11%. Your hospitals need to know this now, and they need to act, because it is so important, because what that's ultimately going to do to the Medicare physician fee schedule, it's going to reduce the technical component for those on the call now who have imaging centers that are physician-owned or IDTFs that get reimbursed by the MPFS. It's going to reduce your CT component by 6% and your MRI by 3% reimbursement for the technical component. Now RBMA, and obviously RBMA, ACR, and hopefully AMA are all commenting on this now as we speak. Also, you need to be prepared that the commercial payers may adopt the MPPR. Now, it's very important to watch that. Here in Massachusetts, one of our payers did adopt the MPPR, saying that it's industrial standard. And I immediately got on the Radiological Society in Massachusetts, commented on this, RVMA National commented on this, ACR commented on this. So this particular payer is starting to back down a little bit and possibly may reverse their payment policy by the end of this year. We're keeping our eye on it. Also, another thing you need to watch out for is steerage by RBM. That's another program that they've sold to payers, that why don't we steer your patient to a lesser expensive image provider. For example, your patient already has been pre-certified for an MRI for your facility. All of a sudden the RBM calls that patient and says, I noticed that you go down the street to mom and pop shop and get your MRI down there. They're supposed to be looking at quality. I don't know if they're actually doing that, and I don't know if they're doing a great job of that, but I do know that their cost is number one, quality is second. I don't know about you, but I care for the patient, and I want them to have the best scan the first time. A lot of patients don't understand that they're being steered to another provider, and why, other than it's controlling costs, but they don't understand they're compromising on quality of their care. Obviously, the next big thing is also in October 2014 is ICD-10. You need to be ready. You need to be ready. Start to get ready now. And I have some of these sites here that you can access to learn more about it if you haven't already started. I'm hoping everyone on this call has started looking at ICD-10. The other thing is you can work with your hospital, because I'm sure they're already on it. And what's to come and how to prepare, again, higher copays, deductibles, watch your self-pay AR. You might want to obtain copays at the time of service because it's very important to get that because it's harder to collect and it's more expensive to collect the copays and deductible after the fact. I'm finding out it's extremely expensive because I don't know about you. Sometimes I get my copay for my office visit in the mail, and I maybe kind of like stick it under my utility bill or whatever and don't pay those right away. I would recommend or advocate that you try to collect the copays at the time of service, advocate for your hospitals to do so, and your imaging centers. Have ABNs and waivers for non-covered services available. Identify what those non-covered services are, and then get their patient to sign them. I've got about 10 more minutes here. Medical exchanges are also something else that you know from the Obamacare Act, that you really have to understand what these medical exchanges are going to do to health care. They're, from what I hear, they're going to start paying lower or below Medicare and Medicaid rates. So that's not good news for us. And then also look at your quality and safety measures. Of course, you've all heard of meaningful use, ACOs, bundled global payments, and then fee-for-service obviously is on the chopping block. Strategies to consider, negotiate or renegotiate your contracts. Don't allow CMS payment reducing policies carry over into your commercial contracts, like I said before. Have safety nets to ensure that payment policy changes don't affect your bottom line. And I can advocate more than now is to get involved with RVMA and ACR right now because we need your help on the advocacy efforts that we have in Washington to stop these cuts because I really believe that they don't understand radiology reimbursement. The more I talk with the government people down in Washington, or if I talk to the payers, for example, Blue Cross Blue Shield of Massachusetts, I went to one of their meetings, they didn't even understand the difference between a TC and a 26, and they're making policies. You need to understand that radiology is very complex. I don't know how we got here and how it got so complex, but you need to make sure that your payer understands how complex it is, and that these cuts continuously happen without giving any consideration what the downstream effect is going to happen. So other thoughts to consider is the question is not if you're leaving money on the table, but how much money are you leaving on the table? It is too expensive to have a perfect system. If it is too expensive, then you need to determine where to stop. I mean, it's not to chase after the chest x-rays. Fine. That's something that's between you and your billing service or your billing office. And also, is everybody willing to roll up their sleeves and go that extra mile to get these things paid? Make sure you have a robust revenue cycle, and so you can determine what can't be collected and budget for that loss. So I'm going to turn over now to Trish to see if there's any questions I can answer.
Thanks, Christine. Thanks for a great presentation. We did have a couple of questions come in. One was in relation to your key indicators at a glance slide with the simple dashboard, and somebody had asked, could you explain what PPO means or stands for?
Oh, PBO?
Mm-hmm.
The PBO is a professional billing office.
Okay. And then the second question that came in is, have you tried using a pre-collection letter before sending a patient to a collection agency?
No, we have not. We don't do that.
Okay.
But what we do, I want to explain that a lot of clients, what they do, or what some of the clients I've had, we also submit what we call a CAR report, and everybody has their own acronym. But what we do is we send the rejected claims before we send them to collections. We send the list of the patients to the referring physician. I'm not the referring physician, to the radiologist, to determine if there's any of these patients that we should not send to collections. To kind of purview that before we send it.
Great, thanks. And several people had asked if, throughout the presentation, if the slides are going to be available after the presentation, and yes, they will be. You will be receiving a copy of the entire slide deck along with an audio playback option so you can take notes as necessary or needed. But that was the only other questions that we had, Christy. So again, thank you for a great presentation. Thank you for everybody on the line who joined us, and look for that email in your inbox later today. Thank you so much.
Thank you.